Hi, my name is Emily Capiluto, and I'm with the Mike Slive Foundation for Prostate Cancer Research. It is my pleasure to welcome you all today to the second of our Cancer Conversation series. Today's presentation will be by Mary Grace Roden, and it is Genetics and Cancer, What Role Does It Play? This speaker series is a collaboration put on between the Laura Crandall Brown Foundation, the Mike Slive Foundation, and Forge Breast Cancer Survivor Center. I'm going to provide a brief information about the Mike Slive Foundation and then pass it over to our other organizers. We were founded with the mission to fund prostate cancer research as well as raise awareness for prostate cancer and early detection through screening. 1 in 8 men will receive a prostate cancer diagnosis in their lifetime, and the first step to early detection is as simple as a blood test. So please go to MikeSliveFoundation.org to learn more.
Hey everyone, my name is Taylor and I am the program director for the Laura Crandall Brown Foundation. Our foundation is on a threefold mission of education, research, and direct patient support, and with emotional or where that be any other type of support that we can possibly give them. We were founded in 2009 and we help women with GYN cancers. If you are a woman on this call that has GYN cancers and needs any type of support, please go to our website at www.thinkoflaura.org, and then there you can see where you can join our Can Survive on Facebook. We appreciate y'all for coming, and we hope that y'all have a wonderful time today.
Hi, I am Claire Gray. I'm the manager of community outreach here at Forge and the third of our 3 partnering organizations. We're grateful that everyone's here today for this collaborative effort. Forge was founded in 2016, and our mission is to support, empower, and improve the quality of life for those living with breast cancer in the state of Alabama. And we do that through a number of different patient-centered approaches, from both virtually, but also from our house, which is in Southside, convenient to many of the health systems that are in the downtown area. You can learn more about our services. They range everything from the emotional support to tangible through helping get you to treatment and help with nutrition as well. So you can find out more about that at forgeon.org. So FORGEON.org. Thanks everybody, and excited for a great conversation today.
Thank you all for joining today's call, and I want to frame the series and how it's going to run today for anybody that's just hopped on. We are recording right now, and then we will turn off the recording portion at the end of the presentation, at which point we will do a question and answer session. If at any point during the presentation you have questions, please feel free to put them in the chat box, and we will be sure to get them asked and answered once the presentation has finished. So it is my pleasure to introduce Mary Grace Roden as our speaker today. She is originally from Cullman, Alabama, and graduated from the University of Alabama with a Bachelor of Science in Biology in 2018. She's now in her 2nd year of the Genetic Counseling Training Program at the University of Alabama at Birmingham, and is currently serving as cancer clinical rotation at West Cancer Center and St. Jude's Children's Research Hospital in Memphis, Tennessee. So please give a warm welcome to Mary Grace Roden, and we look forward to your presentation.
Thank you so much for that introduction, Emily. Let me pull up my slides and we can get started. All right. Okay, can everyone see that okay? Awesome. Okay, so yes, thank you for that introduction, Emily. Like she said, my name is Mary Grace Roden. I'm originally from Cullman, Alabama. Right now I'm in Tennessee, doing some clinical rotations and learning more about cancer and the role of genetics in cancer, which is timely because that's what we're going to be talking about today. So my presentation today is about genetics in cancer and what role does it play. And I'm excited to talk to you all about this. And if you have any questions, we'll open it up for a Q&A at the end. All right, just to give a bit of an overview of today's presentation, I'll be describing the difference in hereditary and non-hereditary cancer. And then I'll explain genes and their role in cancer. We'll also differentiate genetic testing versus somatic testing and break down what that really means. And we'll also review implications if a genetic test result is positive. And finally, we'll discuss when to seek out genetic testing for yourself or for a family member. And then, like I said, I'll open it up to any questions at the end. All right, well, when we think about the distribution of cancer, we think about it in three categories. Cancer can be hereditary, it can be familial, and it can be sporadic. About 80% of cancer, or the majority of cancers, are sporadic or happen by chance. And usually a person is of older age when a sporadic cancer occurs. About 15% of all cancers are familial, meaning that we see cancers clustering in families, but there's not a known hereditary explanation for these cancers. This could be a combination of hereditary and environmental factors playing a role in the cancer development. Multiple family members on one side of the family may be diagnosed with the same cancer, but usually the cancer occurs at later ages, and we don't really see the same patterns that we would see in hereditary cases. Only about 5 to 10% of cancers are, in fact, hereditary, meaning that there is one identifiable inherited cause that is leading to the increased risk of cancer development. In many of these cases, there's a recognizable pattern of cancer on one side of the family that we're seeing. And understanding which category that your cancer or your family member's cancer falls into can help us guide the management of your cancer risks better. So things we're exposed to throughout our lives have an impact on us in developing cancer. For instance, sun exposure plays a role. So does our diet and our weight. Even our exercise can make a difference. Even chemicals and pollution can have a harmful effect. And we know that our genes also play a role in the development of cancer in an individual. Even a combination of these things and age-related factors can play a role in how cancer develops in a person. Today, we're going to be specifically focusing on the role of genetics in cancer development. And there are certain red flags that we look for in a person's personal or family history of cancer that might make us more suspicious for a hereditary condition or less suspicious for a hereditary condition. These red flags include cancer at an early age, and generally speaking, we consider an earlier age to be less than 50. Certain types of cancer may be a red flag. Ovarian cancer, for example, in someone's personal or family history would make us more suspicious for a hereditary cause of that cancer over, let's say, lung cancer, for example. Having multiple generations affected with cancer can also be a red flag. Having a pattern of cancer running in the family makes us suspicious that there could be something that these individuals inherited that are putting them at an increased risk to develop cancer. And I've mentioned the word hereditary a couple of times so far, and I wanted to explain what exactly I mean by that. So we all have thousands of genes in our body, and these genes make us unique and also carry the instructions to help our bodies work properly. We all have specific genes in our bodies whose entire job is to help protect us against cancer. I'll call these genes cancer-fighting genes for the remainder of the talk. So each person has 2 copies of every gene, including these cancer-fighting genes. As you can see in this visual, the mother has 2 copies of a gene, as does the father. When the mother and father have children, they each pass along 1 copy of every gene to their child. This visual shows that their child inherited the orange copy of the gene from the mother and the green copy of the gene from the father. Like I mentioned on the previous slide, we all inherit genes from our parents whose main job is to help protect us against cancer. When a cancer-fighting gene isn't working, it is essentially turned off. We call this a genetic mutation, and it's shown in this visual in the black color. The individual here inherited a genetic mutation from their mother, and a working copy of the gene from their father in green. When an individual has a genetic mutation in one of these cancer-fighting genes, they are at increased risk for certain types of cancer. Most cancer-fighting genes are inherited in an autosomal dominant manner, and that is just a fancy way of saying that there's a 1 in 2 or 50% chance to inherit the genetic mutation from a parent. So in this visual, we see mother and father again with 2 copies of the cancer-fighting genes. But in this case, we see mother has a genetic mutation in one of her cancer-fighting genes, shown in black again. When mom and dad have children, there is a 50% chance mom will pass on her working copy of the gene and a 50% chance she will pass on the genetic mutation. I have the different scenarios shown here. The first 2 children inherited the genetic mutation from their mother and one of the father's working copies of the gene. Both of these children included in the box are at an increased risk to develop cancer because they inherited the genetic mutation from their mother. The other 2 children inherited working copies of the cancer-fighting genes from both parents, so they are not at an increased risk. So again, 50% or 1 in 2 chance of a child inheriting the genetic mutation from a parent. The risk of inheriting a gene mutation is the same for both sons and daughters. So like we discussed at the beginning of this talk, most cancer is sporadic, meaning it happened randomly or by chance, but all cancer has genetic mutations. A somatic mutation is a change in a gene that arose in the tumor, and it is confined to the tumor. You can see in this visual of a genetic change in the green individual, but the genetic mutation is confined to the tumor, shown in pink. A hereditary or germline mutation is a change in a gene that was inherited and is present in all the cells in that person's body, shown by the completely pink individual. This causes that person to be at an increased risk for cancer. And like we reviewed, only about 5 to 10% of cancer falls into this hereditary category. So we've talked a lot about genes up until this point. So what about the role of genetic testing in cancer? So one category of genetic testing falls into testing for hereditary cancers. And this can be done by taking a sample of your blood or your saliva to determine if there's a mutation that was inherited. This information is used to guide risk management options and also helps us understand who else in the family may be at an increased risk for cancer. Tumor testing is another category of genetic testing in cancer. A biopsy or sample of the tumor is taken to understand the genetic mutations present in the tumor. And this can help your doctor determine what kind of treatments would be most effective for the type of cancer that you have. So the two-hit hypothesis helps us understand how cancer that develops in individuals who carry a genetic mutation, as opposed to cancers that develop because of random mutations and otherwise normal genes. So with sporadic cancer, we think about it as a result of accumulation of gene mutations. If enough mutations occur, a tumor can develop. As you can see in this top figure, we have an individual who at birth does not carry a mutation, and both cancer-fighting genes are working like they should. Then there's a random event that causes a mutation in one of the genes. Another random event that causes a mutation in the other gene, and a tumor is formed. So over time, the gene can become damaged, and after some more time, the other gene becomes damaged in sporadic cancer. In the bottom figure, we have an individual who at birth carries a mutation in one of their cancer-fighting genes. So only one random event is needed to cause a mutation in the other gene and the cancer to form. In hereditary cancer, it's like you have one man down in your defense, or you have a head start in developing cancer. This explains why we often see cancers at a younger age in the case of hereditary cancer. So as we've discussed, most cancers happen randomly, so we all have a risk to develop cancer in our lifetime. I wanted to walk through some of the risks for a person in the general population to develop certain types of cancer. So for breast cancer, we know it's a relatively common disease. About 1 in 8 women, or 12%, will develop a breast cancer in her lifetime. Male breast cancer is less common, at less than 1% in the general population, as is ovarian cancer, which occurs about in 1 to 2% of women in the general population. Pancreatic cancer is another rare type of cancer in the general population, occurring in less than 1% of individuals. And prostate cancer, as Emily touched on a little bit earlier, is more common among men in the general population, occurring in about 16%. And then for melanoma, about 2% of people in the general population will have a diagnosis of melanoma. So BRCA1 and BRCA2 are two well-studied cancer-fighting genes. This table breaks down the cancer risks if someone has a mutation in the BRCA1 or BRCA2 genes. In this third column, we see BRCA1 cancer risks displayed. And so for breast cancer with a BRCA1 mutation, that risk is increased to greater than 60%. For male breast cancer, we know that risk is also increased over the general population risk. For someone who has a BRCA1 mutation, ovarian cancer risks are also increased to about 39 to 58%. Pancreatic cancer risks are increased to 5% or less, and prostate cancer risks are also increased. Melanoma risks stay about the same with the BRCA1 mutation. In this last column, we see BRCA2 cancer risks shown. So again, if someone has a mutation in BRCA2, the breast cancer risk is greater than 60%. The male breast cancer risk is about 7%. Ovarian cancer risk is less than BRCA1, but still increased over the general population at about 13 to 29%. Pancreatic cancer risks is also increased from BRCA1 at 5 to 10%, and prostate cancer risks increased to about 20 to 30%. Melanoma risks are also increased with BRCA2 over BRCA1. So while many of these cancer risks between BRCA1 and BRCA2 are similar, there are some slight differences between the risks associated with BRCA1 and BRCA2 mutations, as shown in this table. Generally, an easy way I like to think about it is BRCA1 mutation carriers have slightly higher female risks, and BRCA2 mutation carriers have slightly higher male risks. So while BRCA1 and BRCA2 are some of the most well-known genes associated with an increased risk of breast cancer, there are other genes that we know about that are also associated with an increased risk for breast cancer. Examples listed here include PALB2, ATM, and CHEK2. With some of these genes, there are some other physical features or other types of cancers in the family that may be present that might make us more suspicious of certain genes. Just like there are genes associated with increased risk of breast cancer, there are other genes we know about that increase the risks of ovarian cancer. As you can see here, there's some overlap in these genes. Notice BRCA1 and BRCA2, STK11 were also mentioned on the previous slide. Others that are new here, though, include RAD51D and RAD51C genes and BRIP1 gene. The MSH2, MLH1, and EPCAM gene are associated with a hereditary cancer condition called Lynch syndrome, which is also associated with an increased risk of colon cancer and uterine cancer, in addition to ovarian cancer. Here on this side, I've listed out some genes associated with an increased risk for prostate cancer. Again, we see some overlap with both BRCA1 and BRCA2. Some of those Lynch syndrome genes we talked about with the ovarian cancer risks on the previous slide. And one new one you see on this slide that is associated with increased risks of prostate cancer is the HOXB13 gene. So it's not important that you remember all these gene names that we've just gone over, but I did want to point out the overlap in these genes that we can see for completely different cancers that can be present in an individual or in a family. So with that being said, cancer genetics has evolved beyond just checking for those BRCA1 and BRCA2 genes, as we've discovered more of these cancer-fighting genes and our knowledge of the cancer risks associated with those genes has grown. It's more effective to cast a wide net with a panel approach when doing genetic testing because There's much overlap in the cancer risks for many of the genes we've mentioned today. And we want to make sure we are being comprehensive to get the clearest view of the cancer risks for an individual and their family. Genetic testing panels today can include anywhere from 8 to 80 cancer-fighting genes. We will discuss the role of a genetic counselor in more detail later in this talk, but a genetic counselor can help guide you through this process. In many cases, testing is based on factors such as the types of cancers we are seeing in your personal or family history, and also we consider how much information you want to get back from the genetic testing. So types of results that we can get back from a genetic test, we'll start with positive. When we get a positive result back, we know that means we found a genetic mutation in a gene that increases the risk of cancer. The gene that the mutation is in will help us determine what cancer types you are at an increased risk for, and also guide medical management strategies based on the result. When we get back a positive result, we will also talk to you about family members that would need testing for the same mutation found in you. You can also receive a negative or normal result, meaning the cancer-fighting genes that we looked at with the genetic test are all working like they should. With this result, we aren't exactly sure what caused your personal or family history of cancer, or we can attribute it to a combination of environmental and genetic causes. In some cases of a negative result, there may still be recommendations to watch you more closely with proper surveillance because of your specific personal or family history. You can also receive a result that's kind of in the middle, kind of like a question mark, called a variant of uncertain significance. This means we found a genetic change in one of those cancer-fighting genes, but we don't have enough information at this time to know if that change is causing an increased risk for cancer or not. And like with a negative result, there may be medical management recommendations based on this result if you have family history that would indicate you needed to be watched more closely. So when we do get a positive result back for a patient, what do I mean when I say proper medical management or appropriate surveillance? So based on the gene that comes back with the mutation and what we know about the cancer risk associated with that gene, that helps us determine how to best move forward in taking care of you. Increased and earlier surveillance is an option that some patients choose to move forward with. As an example, with a BRCA1 or BRCA2 gene mutation, this would include an annual mammogram with an alternating breast MRI every 6 months. Some patients may also choose to move forward with risk-reducing surgery. Using BRCA1 or BRCA2 as an example again, some patients may choose to have their breast tissue surgically removed. Some women may even choose to have their ovaries removed as they approach menopause age to reduce those ovarian cancer risks. And there's no right or wrong answer for these options. We would encourage you to have a conversation in more detail with your doctor about options and what would be the best fit for you. And lastly, just encouraging a patient that tested positive to avoid those cancer risk factors that we discussed at the beginning of this talk. Overall, living a healthy lifestyle would be especially important for a person that has an increased risk to develop cancer. So some patients ask if this information could be used as genetic discrimination. And so the Genetic Information Non-Discrimination Act, or GINA, is a federal law that was passed in 2008 that provides certain protections against insurance companies using genetic information against you. So GINA protects patients from discrimination with health insurance. So a health insurance company could not raise or lower your premiums based on a genetic test result. It also protects against employer discrimination. So an employer could not hire or fire you based on a genetic test result. Things that are not protected under the GINA law are life insurance, long-term care insurance, and disability insurance. Some patients may consider postponing moving forward with genetic testing until they get a life insurance policy in place. So where does genetic counseling fit in this picture? As a genetic counselor, we would meet with you for counseling before genetic testing is done to discuss your medical and family history, talk about many of the genetic concepts like we went over today, what may change in your medical management based on what we find, and also help you through the process of deciding if genetic testing is something you want to pursue at this time. If you proceed with genetic testing, the genetic counselor will also be your touch point when the results of your testing come back. They will explain the details of what was found, if anything, and next steps for your medical management from there. They will also talk about who else in the family would need to be tested, if any. A genetic counselor can also provide referrals to any other doctors that may now be relevant to your healthcare based on the genetic testing results, and can also provide you with various educational resources or support group information. So some of you may be wondering if you're a candidate for genetic counseling or genetic testing, and I suggest you use your personal and family history as a guide. Things in your personal or family history to look out for include a breast cancer diagnosis at age less than 45, a breast cancer diagnosis after 45 with a close blood relative with a breast cancer diagnosis, ovarian, pancreatic, or prostate cancer diagnosis. Also, something to look out for is males diagnosed with breast cancer, or 3 or more total diagnoses of breast cancer in a patient where a close relative, a personal diagnosis or a close blood relative diagnosed with ovarian cancer, a personal diagnosis or a first-degree relative diagnosed with pancreatic cancer, or also a diagnosis of metastatic prostate cancer, or prostate cancer that has spread to other areas of the body. So one thing I love about working in this field is that genetic information can often provide us with next steps on how to move forward and best take care of an individual. So I wanted to provide this audience with some action items based on the information that we learned about today. So remember those red flags for hereditary cancers that we talked about: cancers diagnosed at an earlier age, certain types of cancers, and multiple generations affected with cancer. If you think your personal or family history of cancer might be suspicious for a hereditary cause, then reach out to your doctor or healthcare provider about genetic counseling and genetic testing. They could help get you set up with seeing a genetic counselor. It's also helpful to talk to your family about the types of cancers in your family and the ages that they were diagnosed. When you see a genetic counselor, they will draw out your family tree and they will ask about these things during the session. So it's helpful to come prepared to your appointment with that information. I also wanted to make you all aware of how to find a genetic counselor. If you're interested, you can go to nsgc.org and click on the Find a Genetic Counselor tab. This will help direct you to a genetic counselor in your area. I'll also include the link here that will take you directly to that website.